oncologist from
There it goes.
UAMS.
Yeah, there we go.
And he's gonna talk to us about radiation oncology, and I'm sorry, Kara has the bio and she left.
Oh, that's all right.
So I can't
Yeah.
give you
Yeah,
the
there's
whole lowdown. I just want to announce once again, which we'll announce at every meeting, what we talk about is confidential. It stays in this room. So people are free to share or not share as you wish, but we don't go out of here and talk about other people's issues. So with that,
Let's see, how do we get to my computer?
last time we had a remote clicker, but they took away all their equipment. It lives here, so we have to use.
Do you know how to get this to show?
Well, then Kara's gonna have to come back. Pat, are you a good technology person?
No,
Joe, are you?
sorry, not in that
Display
feature.
I can't get to that.
Well, first I'm gonna have to get, you can open the file.
We're trying to get it to, I mean, it's not among my strengths, I'm afraid.
It doesn't seem to be connected.
I mean, I'm sure it's connected, but we just need, oh, yeah, it's not,
It's not connected.
nothing's
is it?
connected to this.
That would probably be the reason. Okay,
On the side.
On the side?
yeah, is it,
Oh, no, this side, oh, this side. Then I have to.
yeah, that's the one,
yeah. You're right.
Yes.
Okay.
Here we go.
Okay. Then I need to. I can't find my computer. I want to open up the flash drive.
Kara might have to come back.
I'm not used to this view. Whatever this is.
You might have to come back.
Can you get there through Windows Explorer? Through the-
We're
just-
having a little trouble.
Does anyone know how to?
On the far left?
Yeah, just that
The bottom left.
file folder icon on the
This
bottom
one?
there.
Can't.
I just want to open up my USB. This flash drive.
Understand.
Yeah.
Yes, 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 we did.
Oh, there. That one. Okay.
That we're just trying to figure out how to,
Yeah, I think we got it.
You got it there.
So we just got to open up the USB.
we gotta open the USB.
And
Is
then,
it
yeah, we're
okay,
fine. We're
Kara?
fine. We're fine.
Okay,
Okay, aeration therapy. Here we go.
okay. Yes, I think so. Still not
Yeah.
showing up on the screen though.
Here we go.
Here we go, okay.
Oh, resolution's not great.
Where is the focusing capability?
That's good.
Doing good.
Is that good? Okay, thank you. Yes, thank you. Bye. Okay.
Well, I'm Dr. Maraboyina. I'm a radiation oncologist at UAMS, and I specialize in treating genitourinary malignancies as well as thoracic malignancies like lung cancers. We have a lot of light shining on you.
That's all right, no
We
problem.
can't do
Looks
anything
like
about
we
it.
It'll be gone in
Oh,
about
it's the
10
top
minutes.
one.
It'll move. It'll be
I
gone in a
recognize
few.
some of the faces from last year, correct? Right. How many people were at that tour we did at UAMS? Just
Great.
okay.
Very educational.
Okay.
We got to do a tour.
Um,
It was very interesting.
Yeah, and so we'll keep this informal, and we have an audience on the Facebook Live. Is there anybody?
Did you click it on?
Yeah, it's on.
It's
It's
on.
on?
Okay, thank you.
Bill Johnson is watching.
Okay. And where are they located?
It doesn't say.
In Texarkana, or is it
No.
south?
No, he's,
Just somewhere?
he's on
somewhere.
our staff, but it's anybody who.
Oh, okay.
We send out notices too. to people
Okay.
They can join
Yeah.
us on Facebook.
So we'll try to keep this informal, but I have several slides prepared, which are informational, but we'll try not to go into too much detail on what are the slides.
Before you move on, can you spell your name?
Yeah, it's
It's right there.
oh yeah, here, let me,
Oh.
there, yeah, it's also right.
There you go.
Okay.
Yeah, and so like I was saying, I'm a radiation oncologist, and I don't have any disclosures. We usually have to start to say that. No financial disclosures, but I do work at UAMS, and if I do say anything, it's related to that, what we have to offer at UAMS. But I understand this is an independent group, prostate cancer support group, which for the first time includes patients from the different groups within Little Rock that deal with prostate cancer, mainly Arkansas Urology, Cars High, and UAMS, and some of the smaller urologic practices. So, so many of you here are here to learn about treatment options for prostate cancer, or have undergone treatment for prostate cancer. That's my understanding. Or maybe you know a family member that's had prostate cancer. So any discussion of prostate cancer, we usually start by risk stratification, and that's based on your PSA, your Gleason score, and what the stage of disease is at initial presentation on a physical exam. And so based on the certain features on those three variables, we can divide prostate cancer into low risk, intermediate risk, and high risk. And does that sound familiar? Because most of the time when I meet with patients, they're like, okay, this is the first time you kind of like put it all together and put me into a risk category. So some of the terms that I'm throwing should be familiar to all. And because the treatment options vary based on what risk stratification you belong to, as well as the outcomes, okay? And so with low-risk prostate cancer, if your PSA is less than 10, Gleason of 6 or less, and the stage is like a T1, meaning there's no palpable disease, you can't feel any disease on the exam, is going to be, and then this is the first line says active surveillance. So active surveillance, that's something that we've been doing that in the last maybe 5 years or so, that we're finding that many men with prostate cancer are being overtreated. So we can, based on what they find at the time of pathology in the PSA, that we can just monitor these patients without any real progression of disease. So active surveillance, or surgery, or radiation. And sometimes the treatment's going to depend on who you meet first. If you meet a surgeon, they want to take it out. If you meet a radiation doctor, they want to radiate you. Well, hopefully not. But it really, ideally, I mean, any discussion of prostate cancer should be with a multidisciplinary team. Urologist, radiation oncologist, and a medical oncologist, just to get all the different perspectives. I mean, otherwise you're just going to introduce bias.
Do they usually meet together? Because I haven't had that. I haven't had them meeting together. Is that
So, I can tell you what we do at UAMS. We do meet together. We try to.
I'm sorry, not to interrupt you. Do they meet together with you, or do they meet together by themselves?
The patient, you mean?
Yeah. Do they?
Oh, so depending on the institution. So sometimes they meet all the doctors at one time. That is, ideally the most beneficial for the patient, because it's one-stop shop. You get to meet all. But in reality, it's to try to coordinate all that. It ends up being meeting each one of the doctors at a different time. But I know at UAMS we're trying to work on and having a multidisciplinary team where the patient just comes in and meets all the team members at one time. And we do that with other tumor sites, but not with prostate cancer at this time. All right. So, like I was saying, treatment of low-risk prostate cancer, active surveillance, radical prostatectomy, which is surgery, and there's different types of surgical options such as robotic prostatectomy or open prostatectomy. And then from radiation standpoint, there's external beam. You can divide external beam or brachytherapy. And I know that you guys were talking about brachytherapy. And there's different forms of brachytherapy in addition to different forms of radiation, external beam radiation. Okay? And then intermediate risk is just your PSA is a little bit higher. They can feel something on the gland at the time of examination, and the Gleason score is higher. It's pretty much the same treatment options as the low risk category, but active surveillance probably plays less of a role. You don't want to really watch these patients, and so surgery in addition to radiation and the addition of androgen deprivation therapy. And this is just the intermediate. And then the high risk, typically they don't offer surgical options because the disease has spread outside of the prostate gland, and it's more of radiation therapy and androgen deprivation therapy, the hormone treatment, the hormone shot. And so there's two forms of brachytherapy. There's high dose rate and low dose rate. And this picture here is showing, and so if you hear about the seeds, the radioactive seeds, this is low dose rate or LDR. And
How many do they do?
how many seeds do they insert? So there's about 10 to 15 seeds per needle, and depending on the size of the prostate gland, they could insert anywhere from 20 to 30 to 40 needles. And this is an outpatient procedure done under general anesthesia.
And these remain, right?
Yeah, these stay.
They don't come out ever.
So they insert. So the needle has several seeds. They insert the needle, and then they pull the needle out, and then the seeds drop into the prostate gland, and they stay there permanently.
Are the seeds, do they have a half-life?
Yes.
And so they last, what, a year or two?
The radioactive isotope is iodine-125 or palladium-103, and typically after several months, there's no activity.
Okay.
So iodine-125 is the most common radioactive isotope. So in the very beginning, when you have the procedure, they say, okay, you can't hold any small children or pets, or can't be intimate because of the radioactive.
Right. Okay.
And so after time, then it goes to negligible levels. Or you can't go to the airport. Or if you do, you have to let them know that you had this radioactive seeds implanted in your prostate. Yes.
The perforation of the margins 20 to 40 times in placing these seeds, does that cause any problems with cancer cells emitting out of the...
No. So I think there's a false belief that any kind of surgical manipulation or manipulation of the capsule of the prostate is going to spread prostate cancer cells. So that does not happen. But prior to doing surgery or a local radiation treatment, we would do an MRI or some kind of imaging to make sure it hasn't penetrated outside of the capsule. Because but it doesn't disseminate cells.
I had a radical prostatectomy done.
Yes.
And for 26 months I had no PSA, and then one showed up.
Yeah.
Now where did the PSA?
That's a good question. That's a good question. So, and we'll get to that. Okay. So when we're talking about prostate cancer, let's divide it into definitive treatment, which means you have prostate cancer. What are my options? And then the other way of looking at it is, you've had your prostate cancer treated, and it comes back. We call that recurrent cancer. So that's a different set of treatment options. Okay? So this is low dose rate brachytherapy. This is kind of gone out of favor. Not many people do it. We're not doing it at UAMS, and I don't know of any practice in the state of Arkansas who's doing a lot. I mean, if you're interested in this treatment, it's a good treatment. It works. It's but if you're going to go to a place that you really need to go to a place that's doing a lot, more than 5 a year, because there's people who are doing it are not doing it more than that. So, and this is high dose rate brachytherapy. It's not as there's not much data compared to low dose rate. And in this procedure, they insert catheters, and then the radioactive source does not stay within the prostate gland. It's not permanent. It's housed in this machine. This arrow doesn't show it, but on this, it's called an afterloader. So it's the size of like a rice kernel, and it goes into the catheter, and it stays in there for like 10 minutes, and then it's pulled out. And so typically the treatments are like twice a day for about two or 3 days. Don't ask me if they leave. They probably don't leave the catheters, but sometimes the patient have to get admitted to the hospital, but yeah, that's how it's done through the catheter, and it's a high dose rate. So the toxicity of radiation therapy is specifically related. Well, any kind of treatment is, you have this prime real estate. You have the prostate gland, which is right here. So the walnut-sized gland right here. And you have the rectum, which is in the back. So when you have prostate cancer and the physician does a digital rectal exam, there you go. You're trying to feel for that prostate. And then here's your bladder right there. So imagine, from radiation standpoint, if radiation is coming from different directions, it's got to go through the rectum, it's got to go through the bladder, and some of the erectile nerves. So erectile dysfunction, diarrhea, urinary side effects such as pain on urination, and frequency of urination. That's because of what's nearby. And when you think about surgery, they're cutting around the what's near the prostate gland, so you can get urinary incontinence because they have to cut the urethra, which goes right through the prostate gland. You have to cut it and sew it back, and so patients are going to get incontinence. And so when we talk about radiation, we can divide it into acute, meaning what kind of side effects are you going to get during radiation in the first 3 months, and then late side effects, which would be years down the line. So like I said, diarrhea, irritation of the bladder, urethra, those are some of the acute side effects. And we talked about brachytherapy. The other form of radiation is external beam. So basically, brachytherapy is internal radiation. The other form is external beam, meaning the source of radiation is coming from a machine, which is the linear accelerator. This is a linear accelerator. This is the one we have at UAMS. And those of you who were at the tour last year, this is the most common form of treatment for prostate cancer from a radiation standpoint. And then you can further divide external beam. I heard you guys talking about IMRT, which is the standard delivery of radiation, and it's just a highly focused type of treatment. And then hypofractionation means doing a shorter course of radiation, and extreme hypofractionation, such as CyberKnife, that's just the name of the machine, that's doing the treatment in 5 days. So a typical course of radiation would last about 8 weeks, daily, Monday through Friday. Moderate hyperfractionation, you can split that into, you can divide that up into 5 weeks of treatment, and then extreme hypofractionation is 5 days. And the latter two are some of the newer forms of treatment. It's all external beam, it's just how you deliver it. And the reason that we can deliver it in a shorter course is that our treatment technology has improved in the last 10 years. Our imaging capabilities are better, and the way it's delivered is better. So we can afford to deliver it in a very focused manner. And this is just comparing the 3D, so 3D CRT is just 3D conformal radiation therapy. It's just like a beam coming in 4 directions, and you get a box, like a square. That's not what, remember I said that it's a walnut, the prostate gland is right here. It's not a walnut, it's a circle. So back in the days, this is what the treatment would look like. And you can imagine the rectum is right there, and then there's the prostate. Your target is there, but you're going to spread the radiation to other areas. So with IMRT, which is the standard way of delivering radiation, you can see how it's not a box anymore. It's shaping towards the prostate gland, and you can spare a lot of this radiation going to the rectum. And typically the treatment lasts about 15 minutes or less. And with IMRT, I mean, we can get it done in like 5 minutes. And this is just looking at the dose of radiation. This is so when I said external beam radiation, conventional 8 weeks, 5 weeks, and then the 5 days. This is just a little highlight from the New York Times. There's popular prostate cancer treatment that can be done in a short course. We haven't been doing it long enough, so we don't have the data, but many centers are doing it. And like I said, it's condensing that 8 weeks of treatment into 5 days. And this is just some of the complications that can happen from radiation. This is like an ulcer, so a damage to the rectum, to the rectal wall. And unfortunately, this patient, it was severe. This is not very common. In this study that was looking at this type of treatment, they were dose escalating. They're saying how high of a dose can we go and do it safely. Unfortunately, in this patient, they went too high, and so they had to back down on the dose. This was UT Southwestern. And there are certain things we can do and this is a newer thing.